Megan. Hello everyone, I'm Norma Tavakoli. I work for the New York State Newborn Screening Program. Today I'm going to be talking about the continuation of a pilot study and patient follow-up during a pandemic. And the second part of the talk will be given by Dr. Gruber, who will give the hospital information, and I'll be talking mainly about the newborn screening part of this pilot study. So this pilot study is to screen consented newborns for Duchenne muscular dystrophy, and we started it last year, and then obviously the pandemic happened. Next slide, please. So we've taken a consortium approach to this pilot study, and as part of the consortium is the New York State Newborn Screening Program, Parent Project Muscular Dystrophy, who spearheaded the project. The consenting is being done at participating hospitals at Northwell Health and New York Presbyterian hospitals. ACMG, MBSTRN, Perkin Alma, and our funders, Sarepta Therapeutics, PTC Therapeutics, Solid Biosciences, Wave Life Sciences, and Pfizer are part of the consortium. And then because we have a second-tier test, we also have a contract with a New York State permitted lab who does the molecular testing. Next slide, please. So the goals of the consented pilot study are to validate a high-throughput first-year immunoassay screen for Duchenne in a high birth number state, which obviously New York State is quite high at 230,000 babies a year. We'd like to optimize a second-tier molecular testing strategy for detecting Duchenne and other muscular dystrophies. We'd obviously want to identify infants who are going to develop Duchenne before clinically detectable symptom onset, and this will allow the parents the opportunity to see a subspecialist to confirm the diagnosis, determine a treatment course for the baby, and allow the family to participate in clinical trials. We will be using the results of the pilot study to provide evidence that's required for state and federal assessments of the benefits and risks for performing newborn screening for Duchenne. We'd also like to develop the infrastructure to educate parents and healthcare providers about Duchenne newborn screening. And finally, we'd like to use the data to nominate Duchenne to the recommended uniform screening panel in the United States. Next slide, please. So our screening strategy is to receive newborn screening collection forms at the New York State Newborn Screening Lab. Those specimens are then tested for the newborn screening panel. At the same time, any baby who is consented to the pilot study will also be tested for creatine kinase MM. Any baby with CKMM below the cutoff would be a screen negative. Any baby in the borderline category, we'd request a repeat for that baby. And any baby above the referral cutoff, the baby would be referred to the specialty care center at Northwell Health or New York Presbyterian hospitals. And then a second specimen, either blood or saliva, will be collected for next generation sequencing for Duchenne, deletion duplication analysis. And then if no mutations are found, then there'd be next-gen sequencing for a 46-gene panel, neuromuscular panel. And then the results would be available to the specialty care center and the newborn screening program. Next slide, please. So we started the pilot on October 1st, 2019. Between that time period and February 2020, we'd screened just over 7,000 babies. And then obviously the pandemic hit New York quite hard in February and March. And on March 2nd, New York City hospitals started to inform us that parents were refusing to come for repeats. The outpatient clinics were closing. Families were not allowed back to the floor. On March 23rd, the couriers were no longer allowed to some nursery floors. Pickup locations for specimens were changed. On March 24th, we were alerted about the possibility of early discharge for mothers and their babies, and that meant that specimens were going to be collected earlier than our recommendation, which is between 24 and 36 hours. On March 30th, the specialty care center staff redeployed to some emergency departments and ICUs, and specialty care centers started using telemedicine. Newborn coordinators were no longer able to access paperwork or accept presumptive calls. And then on March 15th, here in the program, at New York State Department of Health, non-essential staff were reduced by 50%. Obviously, newborn screening is part of the essential staff, so the lab staff were coming into work. On March 19th, we were reduced by 75% for non-essential staff. On March 20th, it was only essential staff, and then on March 28th, New York went into a full pause, and so non-essential businesses were closed. Next slide, please. So here I've listed some of the things we had to do as a response in the newborn screening program in general. Across the organization, or anyone who came to work had to have their temperature checks, and everyone had to wear masks. Here in the newborn screening program, we were not performing testing on Saturdays or Sundays, but once the pandemic happened, then we went into Saturday testing to make sure we had manageable numbers on the following weeks, on Monday and Tuesday. We set up remote connection to lab instruments so that staff could see lab results from home. We had already started cross-training staff pre-pandemic, and so that was very useful as we were able to use staff in different areas. Some staff were also working second shift, so this was working in the evenings. Staff were also helping with accessioning specimens for COVID-19 serology. So some staff were, in addition to doing their newborn screening work, were also working evenings and weekends for COVID-19 serology. Our data entry and follow-up staff were working remotely, or they'd been moved to a different building, and that was because some of the offices that they were using here in our building were now used for COVID-19 testing. We also had to change some of the language on our reports. So, for example, we asked for repeats to be collected when practical, when risk was low for those babies. We created educational packages for PCPs in case families visited PCP instead of the specialty care center. We alerted the specialty care center to the changes that we were making, and we requested that they give us updated emergency contact information. And we were also in contact with all of our vendors to make sure they were aware of our needs and that we were aware if there was ever any shortage on their end. Next slide, please. So in terms of the pilot staff, we obviously started in October, and then in February and March, we had discussions with the PIs and staff at the hospitals regarding how we were going to proceed if the pandemic got worse. So the hospitals had developed remote recruitment and also remote follow-up, that they were seeing patients by telehealth. The newborn screening program then developed protocols in response to remote recruitment from the hospitals. So the modifications that we made to the protocol were then written up and submitted to our IRB for approval. And on April 1st, 2020, the hospital started remote recruitment and follow-up. Next slide, please. So in terms of the lab response to the pilot study, in my lab, there's one person who is paid on the grant that allows us to do this pilot study, but we also had two other people fully trained to perform the pilot protocol from beginning to end. We had discussions with PerkinElmer regarding shipping us reagents. They are actually based in Finland, so it's an international shipment. We had to make sure that we were receiving those in time. In fact, we did have a couple of cases where shipments were lost and then showed up after 2 weeks, and we couldn't use those reagents anymore because they were no longer, the cold chain hadn't been maintained. So it was a good thing that we asked very well in advance so that they could ship us the next shipment. And then because the hospitals were now doing remote consent, some of the consent was being delayed, and so we had to change our workflow here in the program. So we received a daily list from each hospital regarding the babies who'd consented. Some of those babies we already had in-house, and we had started their newborn screening for their routine newborn screen, and so we didn't want to hold back those results. So we released those results, and then we manually scheduled the DMD test in our LIMS system. We then pulled specimens from short-term storage because these specimens had already been tested and were already in storage. We had to pull them individually, test them, and then send out an amended report. And this helped us from causing a delay in reporting our newborn screen results. So what we learned is that we need a very flexible limb system, and unfortunately our limb system was not particularly helpful. And so a new module is being created by the manufacturer. Unfortunately, this is probably not going to be in effect for the next few months, but at least, you know, in future we will have a new module that will help us with this process and make it less manual. Regarding our borderline cases, we changed our report so that we asked for repeat specimens when practical. We also expected delays for receiving repeats and closing cases because we knew that families would be less likely to want to go back in to have either a repeat collected or follow-up performed for their baby. We also expected fewer specimens for screening because of the remote recruitment. Next slide, please. So this slide shows you the volume of specimens that we tested from October 2019 through October 2020. As I mentioned earlier, we started the pilot with using in-person recruitment. So our numbers started going up initially as more hospitals joined the study. And then we had our highest number, approximately 1,700 babies recruited by February of 2020. And then numbers started going down. And then in April of this year, we started remote recruitment. And again, hospitals ramped up. And in July of 2020, they moved to in-person and as well as remote recruitment. And so by October of this year, our numbers have gone up to over 1,900. Next slide, please. This shows you the same data in graph format. So you see that the numbers started going up as more hospitals joined the study. And then because of the pandemic, numbers went down. We started remote recruitment and then in-person recruitment as well as remote recruitment in July, and numbers have been going up. Next slide, please. So in terms of our follow-up of our cases, we've received repeats on 92% of our borderline cases. 6.5% of families refused the repeat draw, and 2% have not submitted a repeat yet, but we expect them to in the next couple of weeks. In terms of closing referred cases, we've managed to close 35% of the cases so far. And obviously, second-tier testing is still ongoing on some of those babies, so follow-up is still continuing on the remaining babies. Next slide, please. So key points from this pilot study is that flexibility is very important. So I've written it in capital letters. We've tried our best to be as flexible as possible because we know that the hospitals are on the front line. So any process, any protocol change that they make, we try to fit that into our protocol. We've also obviously learned that we needed a flexible limb system. Ours has not worked as well as we had hoped. And then in terms of pilot studies in general, we think that mass communication, so educating families about the pilot and educating healthcare providers about the pilot will really help increase the numbers of participants. Obviously, we need backup staff because of the pandemic. We also need to plan for shipping delays. So we've had delays in specimen receive and also in receiving supplies. So we always need to plan for those. Not so much in our pilot study, but across the Department of Health, there have been reagents and supply shortages. So for example, gloves, tips, plates, things like that have been in short supply. And then in general, facilitating the consent process. So for example, informed dissent versus informed consent will really help pilot studies improve their recruitment, and obviously increasing options for obtaining consent, such as we have done in a couple of months, in recent months. So we've included in-person, online, phone, and mail recruitment. Currently, we're poised to return to pandemic measures. Thankfully, we have those protocols in place now. We have been using them since April, and so that will help us going forward with this pilot study. Next slide, please. So there are many individuals and organizations who've been involved in the pilot study. I'd like to thank them all. Dr. Michelle Kijana is the director of the New York State Newborn Screening Program. Sanju, Brianne, and Melissa are 3 research scientists who work in my lab and have been doing the day-to-day work on this project. I'd like to thank the Duchenne Steering Committee, PPMD, Doctors Gruber, Tigay, and Chung at the Northwell Health and New York Presbyterian Hospitals, Annie Kennedy at Every Life Foundation, obviously MBSDRN, ACMG, Perkinelmer, and our funders, and I'd like to thank you for your attention.